following me and colleagues and things. It's a good way to keep in touch. So that's the end of that bit, but I just want to come on to some stuff that I'm involved with, but it's not part of the main research that I work on, but I do think is really exciting and I wanted to share with you. So progressive MS, where are we at and where are we going? And just a few slides to tell you about what's happening at Queen Square. Now, progressive MS can either arise after the relapsing remitting phase, so after people have had relapsing and remitting MS for some time, and some people, maybe about 2/3, will go on to develop secondary progressive MS. But in others, the course of MS can be progressive from the beginning, and that's what we call primary progressive MS. The mainstay of our treatments at the moment for the progressive forms of MS is to manage the symptoms. So if someone's got walking troubles, input from a physiotherapist, treat their spasticity, treat their foot drop. If someone's having problems with their bladder, help from a urologist and so forth. But the treatments we've got at the moment, we don't have anything that can slow down the progression or even stop the progression of progressive MS, and that's what we desperately need. Now, Dr. Brownlee mentioned this study, and I just wanted to tell you about it in a little bit more detail. It was a negative study. However, it's shown us that we can do very big trials in primary progressive MS, which is quite a lot less common than relapsing remitting MS. So the INFORM study, they got 970 people with primary progressive MS, and it was there were sites all over the world. There were no sites in New Zealand, but there were sites in Australia. And I saw personally about 30 people from the study who are involved with it in London, so I've had quite a fair amount of involvement with it. The patients were randomised to either Gilenya, fingolimod, which we're going to be hearing a bit more about from Dr. Willoughby shortly for relapsing remitting MS, but this was a trial in primary progressive, or placebo. And they followed them up for 3 years. Now, unfortunately, at the end of the 3 years, there was no difference between the two groups. So the treatment with Gilenya didn't seem to help people with primary progressive MS. They studied them with MRI scans, and the Gilenya actually had an effect on the MRI scan. It reduced the number of new brain lesions forming, but it didn't affect the rate of brain atrophy. And I think that goes back a little bit to what we were saying at the beginning, that the lesions on the scan are part of the story, but they're not the whole story, and they may be more important early on and less important later in the course of MS. Something that was also done as part of the study, but the results aren't available yet, is they measured spinal cord atrophy, like I was showing you before, drawing around the spinal cord to look at shrinkage there. And that shows you how this MRI research is taken forward from the stage that I study it into a clinical trial to help us prove whether these treatments work or not to help people with MS. Fingolimod is one of a number of agents that haven't been shown to help when people are in the progressive phase of the illness. And so if these anti-inflammatory medicines, like fingolimod and others, aren't working, it suggests that there's something different happening in progressive MS that's not happening in relapsing remitting MS, and treatments that target the inflammation aren't effective. Another thought, instead of targeting the inflammation, what if we use treatments to protect the nerve cells? We know that the nerve cells are being lost in people with MS at a rate that's higher than the rest of the population. What about medicines that can protect those nerve cells? And this is a trial that's been completed. I saw some patients as part of this trial and was reported earlier this year. And it was a trial of 140 people who had secondary progressive MS. And they either got simvastatin or placebo. Now, some of you might be familiar with simvastatin, some of you may even be taking it. It's a medicine that lowers cholesterol. And in addition to lowering cholesterol, it seems to have some effects on a whole range of things. The cholesterol just seems to be part of the story. And it had been tried in a very small number of people with MS, and the signal was that maybe you should try it in a larger number to see what happens. And this is a small study. You need thousands of people, well, not thousands, but several hundred people usually to show an effect of a treatment. But if you use an MRI as the outcome instead of a clinical outcome like walking, for example, then you might be able to show the effectiveness of a treatment. And what they found was that 2 years with very high doses of simvastatin reduced the rate of brain atrophy. So it slowed the rate at which brain atrophy was occurring in this group of people who had secondary progressive MS. Now, I don't want everyone to go home and make a doctor's appointment for Monday morning to go and start on high-dose simvastatin. Okay, these results are interesting and they're really encouraging, particularly because it shows us that we can do trials like this and we can prove that these treatments are helpful. But we need to confirm the results in a much larger group of people. Okay, we wouldn't be able to justify the potential risks of very high doses of this medicine, which can include muscle weakness, which is the last thing someone with secondary progressive MS would want, before we can recommend it to people. But I think this is extremely encouraging. Another trial that we're running at the moment in London and has been recruiting since December is also looking at some other treatments that might be able to protect nerve cells. And like simvastatin, there are 3 medicines that are already available. For the most part, they're fairly cheap and fairly well tolerated. So one of them is a medicine called fluoxetine, which is a treatment for depression. Another is a medicine called amiloride, which is an old-fashioned treatment for high blood pressure, not used so much anymore. And the last is a treatment called riluzole, which is an established treatment for a condition called motor neuron disease, which is quite different from MS, but there may be some overlap in the chemicals and things in the brain. All of the medicines are very safe, easy to use, and cheap, and in very small numbers of people, like that simvastatin study, have been shown they may have an effect on protecting nerve cells. Like the simvastatin study, the main outcome is going to be the MRI. So what happens to brain atrophy? Can we slow the development of brain atrophy by protecting these nerve cells? The trial's running from 2015 to 2017, and we're hopeful to, in the next 5 years, to have some results with these medicines. Now, the very last thing I wanted to just tell you about is something that's hot off the press from some research that we've been doing on our clinically isolated syndrome, our CIS cohort, looking at these normal appearing tissues. So we used a special type of MRI called MTR, and they did that when people came at the baseline, and then after 1 year, 3 years, and 5 years. And MTR gives us an idea of the density of nerve cells and the density of myelin. And a very, very bright neurologist from Italy had noticed that when he looked at MRI scans, that there was more lesions, particularly around the ventricles, that had greater loss of nerve cells. And so he used this MTR to look at the density of nerve cells and myelin around the ventricles. And what he found was that there was severe loss of myelin and nerve cells around the ventricle, and there was a gradient. The further you got away from, I should just say the ventricles are the bits that contain the spinal fluid, the cerebrospinal fluid in the brain. They're the hollow bits in the middle. What he found was that the further you get away from the ventricles, the less change you get. So there was this gradient of the normal appearing tissues, the bits where we can't see anything on the scan, were most abnormal around the ventricles, and the further you got away, the more normal they become. And that's really interesting, because we think about MS as being outside in. The trouble is lymphocytes, white blood cells, getting into the brain, causing inflammation and demyelination, wreaking havoc, and forming those lesions. But what if it's the other way around? What if the main problem in MS is something wrong in here, in the cerebrospinal fluid. And we know that when you do a lumbar puncture, it's abnormal in more than 95% of people with MS. We've known that for 50 years, that there's these changes in the spinal fluid. The medicines that we're using that stop things coming into the brain, maybe the problem is actually in the brain itself. And this is relevant because this is what we call compartmentalized inflammation. So the inflammation is all occurring in the brain itself rather than the inflammatory cells coming into the brain. And that might be what drives progression of MS. So in relapsing remitting MS, in the early stages, it's things coming into the brain that are causing the troubles. But as you go along, it's what's actually happening in the brain itself rather than immune cells coming in. And this is relevant because there's a trial going on where instead of giving the treatments intravenously or a tablet, they're giving the treatment through a lumbar puncture. So the drugs are being given into the spinal fluid. And this is sort of very preliminary, but it's not related to the work we've been doing with MRI, but it's, other people are thinking about this as well, that maybe we need to target our treatments into the spinal fluid. And a lumbar puncture sounds, I've never had one, but it sounds worse than it actually is, and it might be a way that we're going to be treating MS in the future with what we call intrathecal, so directly into the spinal fluid treatments rather than intravenous or oral. So there's been just this explosion of new MS treatments, as Dr. Brownlee was saying, that have really focused on the relapsing phases of the illness. And what I think is really exciting is that in the next 10 years, we're going to be getting treatments for progressive MS, and we're going to be targeting treatments more appropriately. So once again, thank you for your attention. Thank you to the MS Society for the sponsorship to be here, and for the Neurological Foundation. Thank you.